Hello everyone. Today I'm going to open చేసాను open చేసాను పక్కన excuse me for the disturbance. So today's class is about cystic disease and vascular disease. We have talked in the last class about glomerular diseases and the tubulointerstitial diseases. We've also spoken about the glomerular diseases in detail, the nephritic and nephrotic syndrome. So today the class is about the congenital malformations, including the cystic disease, the adult polycystic kidney disease, and the infantile polycystic kidney disease, the vascular diseases, benign nephrosclerosis, malignant nephrosclerosis, and the thrombotic disorders, which also include the vascular disease. Okay, so like any other organ, the kidney, if it is not properly formed, it can lead to congenital malformations. So the abnormalities in the amount of renal tissue can be seen as two conditions, that is the renal agenesis and hyperplasia. As you know, the renal agenesis is nothing but the absence of the renal parenchymal tissue altogether, and hyperplasia is about decrease in the amount of the renal tissue. Okay, the complete absence is agenesis, decreases hyperplasia. Anomalies of position, form, and orientation can be seen in form of a renal ectopia. Ectopia is nothing but a misplaced. The kidney should be placed properly for its function to be normal. So if it is not placed properly, and usually the renal ectopia is usually seen where the kidney is situated in the pelvis. Okay, so what happens is that the function may be retained, but it can be leading to extra infections and obstruction due to its location. Horseshoe kidney. Horseshoe kidney is the one in which the lower poles of the two kidneys are fused. So because of that, there may be a problem with the ureter. Okay, and this horseshoe kidney can be associated with the atretic ureter. Okay, so this is the anomalies of position, form, and orientation. Anomalies of differentiation is cystic disease of the kidney, which we'll talk in detail. So the cystic disease of kidney can be congenital or acquired. It can be non-neoplastic, neoplastic, can occur at any age. So what is the presentation? What the person comes to you when the person is suspected of having the cystic kidney diseases? Usually there should be an abdominal mass. Because of enlarged kidney, there can be a push on the diaphragm and may cause respiratory distress. And the cystic diseases of the kidney, I told you, the congenital malformations also can be associated with pulmonary hyperplasia, can be associated with infection, hemorrhage, and neoplastic transformation. So I told you the classification, the non-neoplastic cystic lesions, acquired cystic lesions, and the neoplastic cystic lesions. In that, now we'll see what categorize are present in the non-neoplastic cystic lesion, that is multicystic renal dysplasia, polycystic kidney disease, dominant recessive types, medullary cystic disease, simple renal cells, acquired renal cysts, and pararenal cysts. Neoplastic cystic lesions are associated with cystic nephroma, cystic partially differentiated nephroblastoma, multifocal cystic change in the Wilms tumor. Okay, these are all the tumors which are associated with cystic change, and then they are classified into neoplastic cystic lesions. So now coming to multicystic renal dysplasia. Multicystic renal dysplasia is usually seen in infants. It can occur sporadically or can be familial. As you know, whenever there is a dysplasia, the term, we usually use it where there is something abnormal. There is no uniformity. Okay, there is no proper formation. So here, it can be associated with obstructive abnormalities of ureter. It can be unilateral or bilateral and is usually cystic. So what is the pathogenesis? Whenever there is an abnormality in the metanephric differentiation, there is persistence of abnormal structures. So these abnormal structures or primitive structures can be seen in the kidney when you do a hemisection or crossing itself. So in the microscopy, you find abnormal cartilage, undifferentiated mesenchyme, and immature collecting ductules. So the cross looks like a bunch of grapes because of the cyst. Then the normal parenchyma is totally obscured. Because of this, the calyces, the pelvis, they are not recognized. Ureter is either absent or atretic. So the microscopy characterized by undifferentiated mesenchyme. So what do you mean by undifferentiated mesenchyme? That means it can have a primitive smooth muscle, cartilage, immature collecting ducts. Okay, and then cyst represents the dilated tubules. When it is unilateral, see I told you that it can be unilateral or bilateral. When it is unilateral, it is usually having good prognosis. So this is about multicystic renal dysplasia. So here you can see this is the kidney. You have seen multiple cysts here. You can't differentiate. The reniform shape of the kidney is not seen. You can see that the renal, pelvis or the cortex and medulla, everything is obscured. You are not able to make it like a normal kidney. So this is a hemisection. So here you are seeing the histopathological picture wherein you are finding this immature cartilage, the blood vessels, the immature tubules, and the immature glomeruli. Okay, so this is the microscopic picture of multicystic renal dysplasia. So just remember, multicystic renal dysplasia as a congenital malformation is cystic. Complete cystic formation, walla you can't differentiate between the normal renal cortex or medulla pelvis. Then immature cartilage or immature mesenchyme and abortive tubules are present. Just remember this, that's it. So here again you are seeing the dilated cyst, the cyst-like epithelium here, and then that is flattened. The primitive mesenchyme that is in form of an immature cartilage. So now coming to after multicystic renal dysplasia, we're going to see the PCKD, the polycystic kidney disease. It is usually two types, the autosomal dominant, usually seen in the adults, and the infantile type, that is autosomal recessive. Okay. So, coming to the pathogenesis, when we say that it's a congenital malformation, usually there can be some genetic mutations that can give rise to that. So, these genetic mutations are usually seen in PKD1 gene, that is in chromosome 16, and PKD2 accounting 50%, that is chromosome 4. So, what is it? The PKD1 gene encodes for the polycystin 1, which is an integral membrane protein that is seen in tubular epithelial cells. This is important for the cell-to-cell and cell-to-matrix interactions. And the PKD2 gene in the polycystin 2, it is in all tubules. It acts as calcium permeable cation channel. So this defect causes disruption of the intracellular calcium. So we are seeing two genes responsible. One is seen with the cell-to-cell, cell-to-matrix interaction, the polycystin 1. The polycystin 2 is in all the tubules, which is associated with the functioning of the calcium channel. So this is the pathogenesis. Either it is a mutation in the 1 or 2 gene with the lost matrix interaction. So I told you the tubular epithelial cells and all the tubules are should have a normal growth and differentiation. That doesn't occur, so that will result in the abnormal cellular matrix and cell proliferation and fluid secretion that will cause a cyst formation wherein there can be a vascular damage or interstitial or inflammatory pathology. So how does an adult polycystic kidney disease look like? Usually they are bilateral, symmetrically enlarged up to 4 kgs. The surface is lobulated. There can be multiple tiny cysts of 4 to 5 centimeters with clear straw color to reddish brown. Okay, may not involve the pelvis. Okay, so Whenever you talk about a polycystic kidney disease, remember you'll talk about whether it is infant or adult, what mutation is it involving, bilaterality or unilaterality, how is the surface and how is the cut section. Remember all these 5 things to differentiate between the adult and infantile type. So we are finding the kidney having multiple cysts. See, the kidney is usually enlarged. Okay, completely having a lobulated surface. This is a heavy section wherein you're finding the multiple irregular cysts. Okay. This is another heavy section, and this is another one. So here you're seeing the adult polycystic kidney disease, the lobulations in the form of a figure, and then here the variably sized cysts in the hemisection. So in the microscopy, even in the cyst, we'll be able to recognize that they arise from all parts of the nephron. How do you recognize that? Because we recognize it because of the glomerular ducts, some containing lining of the tubules and ducts, where we can say that the adult polycystic kidney can be associated with some infections like pyelonephritis, and it can have some vascular changes, nephrosclerosis, interstitial fibrosis, and inflammation also when it is chronically present. So the clinical features, though it is a congenital malformation, the adult may not show any kind of symptoms till he reaches his 3rd to 5th decade. Usually presenting symptom is dull, ache or flank pain, hematuria, hypertension, proteinuria, urinary tract infections, and sometimes it is considered a systemic disease with associated congenital malformations in the form of cysts, also seen in the pancreas, liver, lung, and berry aneurysm. So it can be associated with other congenital malformations. Coming to the infantile polycystic kidney, it is less common, whereas adult type is more common. It is autosomal recessive, whereas adult type is autosomal dominant. Bilaterality can also be seen. Presentation can be seen in perinatal, neonatal, infantile, and juvenile. Severe conditions may have thing like failure to thrive. So grossly, the kidneys are enlarged with smooth surface, whereas in the adult type, you are seeing lobulated surface, have sponge-like appearance. The cut section, small fusiform cysts radiating from the medulla to outer cortex are seen. Here you can see the pelvis, calcis, ureter, small and normal. Okay. So here you are seeing the smooth surface in the ARPRKD, and then here you are seeing the hemisection showing the tiny fusiform cysts. The smooth surface with the tiny fusiform cysts. So microscopy, you're finding uniform cuboidal cell reflecting the origin of the collecting ducts. Many of the glomeruli are also dilated. So, clinical features, perinatal period in the adult, we are saying it's 3rd to 5th decade, associated with hepatic cysts and congenital hepatic fibrosis, splenomegaly, and portal hypertension. Even adult polycystic kidney disease can have cysts in pancreas, liver, lung, and berry aneurysm. So these are the differences. You are seeing the genes, that is PKD1 accounting to the adult polycystic kidney disease, that is polycystin, and ARPKD, that's fibrocystin. And then incidence, more common, which is more common and which is rare. And then age at presentation, and symmetrical bilateral enlargement, macrocysts and fusiform cysts. Asymmetric cysts, the manifestations which include the congenital hepatic fibrosis in the ARPKD and cysts involving other organs in ADPKD. So coming to the other one, that is a medullary cystic disease. There are 2 types, that is medullary sponge kidney and nephrosclerosis, which is medullary cystic disease complex. It is autosomal dominant and asymptomatic, and patient is usually seen with the incidental findings. So what is a morphology? Usually the kidney is enlarged, normal, or shrunken. It can be depending upon the severity of the disease. Okay, that is secondary pyelonephritis. The cut surface shows multiple cystically dilated papillary ducts which may contain spherical calculi. Okay, So basically, you have to remember the type of cyst and the age of presentation and how it is presentation. Is it associated with any other disease or not while we're talking about polycystic disease. So after medullary, we are coming to simple renal cysts. It's usually post-mortem finding, more in age of 50 years. The complications lead to hemorrhage and infection, but is usually acquired and rare in infants. So how this acquired renal cyst we can see in the form of trauma, in the form of any cystic degeneration and carcinoma, tuberculosis of kidney, hydrated cyst, and dialysis patients where they are getting treated for their chronic renal or failure or CKD. So here we finished about the cystic diseases of the kidney, the adult polycystic, AR, PKD, that is the infantile, the medullary, and the acquired and the simple cysts. Okay. Now coming to renal vascular diseases, that is a part of a systemic disease. Usually it is more common like that. Isolated kidney diseases can be present but are rare. Now systemic diseases that can affect kidney are hypertension, that is bilateral cortical necrosis, vasculitis, thrombotic disease, DIC, SLE, sickle cell disease. Hypertension will be dealing in detail about benign nephrosclerosis and malignant nephrosclerosis. Nephrosclerosis is the pathological term used to describe the sclerotic lesions that happen as a result of the vascular injury. Okay, bilateral cortical nephrosis, when it is diffuse, it can be seen in obstructive emergency leading to some fibrin clots, and that can be usually seen in the cortex. Vasculitis, I told you, it can be associated with when we are dealing about the rapidly progressive glomerular nephritis. We spoke about the immune type of RBG, and wherein the vasculitis is one of the cause. Right? Thrombotic disease and DIC, disseminated intravascular coagulation, can also affect the kidney. Lupus erythematosus with the immune complex deposition can cause an injury because of the degradation of the complexes. Then sickle cell disease, usually the patient is asymptomatic, present with asymptomatic hematuria. Because of that, there can be some infarction. Casts are usually rare but can be seen. And then in the sickle cell disease, we usually see that there can be necrosis and fibrin deposition and all associated with the disease. So now coming to hypertension in detail, most common cause of renal failure in older adults. Diastolic BP is taken into consideration where it is more than 95 mm or higher. Two types, when we are dealing about vascular disease, we already know what happens to the vessel as per se, right? It is benign hypertension, which is long-standing. Malignant hypertension, males are more commonly affected. Younger age group, diastolic pressure more than 115 mmHg. There can be malignant crisis, wherein malignant hypertensive crisis, wherein there can be papilledema, cerebral edema, retinopathy. It can lead to ARF and CRF, right? So, any hypertension now can be primary or secondary. It is primary, it is idiopathic. Secondary hypertension can be attributed to anything like vascular causes, atherosclerosis, endocrine causes, that is adrenocortical hyperfunction, renal causes, acute glomerulonephritis, chronic glomerulonephritis, renal artery stenosis. Renal artery stenosis can occur as an atheroembolic disease, or it can be caused because of the embolic foci from the heart, or when present, they will try to obstruct the normal functioning of the kidney, so thereby it can cause secondary hypertension, also vasculitis. So now coming to benign nephrosclerosis, you know that whenever there is benign nephrosclerosis, it is affecting the renal arterioles and the small arteries. So what happens because of that? There will be focal ischemia of the parenchyma. Okay, so The underlying pathology is glomerular sclerosis, chronic tubular interstitial injury. So because of that, there is overall functioning renal mass is getting reduced. So it is compatible with life, usually asymptomatic, dies of some of the chronic complication. Here the blood pressure is important, the systolic less than 180, diastolic less than 120. And if it is more, we categorize that into malignant nephrosclerosis. Pathogenesis is by medial and intimal thickening as a response to hemodynamic changes, aging, and genetic defects. Hyaline deposition in arterioles caused by partly extravasation of plasma proteins through the injured epithelium. Okay. So if you remember the blood vessel chapter, there we have already seen what happens in hyaline arteriosclerosis and all. That is almost the same which is happening in the benign nephrosclerosis, wherein the vessels in the renal parenchyma getting affected, right? So what is happening is the same, okay? So that is medial and intimal thickening, hyaline deposition. See, hyaline deposition is because of extravasation of plasma proteins. Okay, so morphology, kidneys are smaller than normal because reduction of the functioning renal mass, and usually bilateral because it is present as systemic disease, the overall blood pressure of the person is getting affected. Surface fine, even granularity or grain leather, contracted granular kidney is the term actually used for description of the benign nephrosclerosis. Cortical scarring and shrinking. So microscopy, we find hyaline arteriosclerosis, it's narrowing of the lumen in the small arteries. Then what you see is glomerular sclerosis, tubular dropout or tubular atrophy, and interstitial fibrosis. Here, so there can be medial hypertrophy, that is thickening, reduplication of elastic lamina, fibroelastic hyperplasia, glomerular hyalinization or extracellular matrix deposition is happening because of the injury, because of ischemia to the glomerulus. Then tubular atrophy, periglomerular fibrosis. Okay, so you can see here in the gross picture of the kidney showing the granular cortical surface, which is in the benign nephrosclerosis. Okay, this is in the high bar picture. And here also you can see the same. See here, you are seeing the hyalinization. Here you are seeing the malignant hypertension. This is the onion skinning change, which we'll be talking just now. This is the onion skinning change that you see in malignant nephrosclerosis. This is the hyaline arteriosclerosis. This is the vessel. You're finding the changes, and here also you're finding some the same changes. Periglomerular fibrosis here, and then there is some hyaline droplets that are insulated in the tubules. Okay, this is the hyaline arteriosclerosis of the vessel. Same hyaline arteriosclerosis. So what are the clinical features? Renal insufficiency. As you know, hypertension is a chronic process. Uncontrolled hypertension can cause benign nephrosclerosis. Renal failure, usually late. Malignant form can supervene. So now coming to malignant nephrosclerosis, as we know, it is more than 180 mmHg and more than 120 mmHg in the diastolic. So occasionally it can happen in non-hypertensive individuals, but it can happen in benign nephrosclerosis patients, and it can cause an underlying cause. Okay, so it is usually of short duration. Even in the short duration, it can have long-lasting effect causing renal failure, anemia. I told you there can be encephalopathy and papilledema when there is a crisis. So what is the pathogenesis? The vascular damage is usually to the kidney, wherein there is increased permeability to the fibrinogen of the small vessels. So whenever there is an endothelial injury, there will be protein exudation and platelet deposition to seal it off. Then appearance of fibrinoid necrosis of the arterioles in the small arteries with intravascular thrombosis. So because of that, what happens? There can be mitogenic factors which are released from the platelets. Then what all this will release in the hyperplasia, and this hyperplasia thus will be termed as a hyperplastic arteriosclerosis. So there is an endothelial injury happening, and because of that, there will be some factors which are coming to play so that it will seal it off. So because of that, there will be increase in the layering of the vessel that is leading to the hyperplastic arteriosclerosis. Typical of malignant hypertension, thus narrowing the lumen and will cause renal ischemia. So because of the narrowing lumen, what happens? Renin-angiotensin system is activated, vasoconstriction of the afferent arteriole will happen, and the cycle is just going on. And aldosterone levels are also elevated. Because of that, aldosterone will cause salt and water retention, which will also contribute to the pathogenesis of increased blood pressure. So morphology, finding the kidney size depends upon the duration of the hypertension. And in contrast to the benign nephrosclerosis, we have a flea-bitten kidney here, that is small pinpoint hemorrhages that occur on the cortical surface of the kidney. In benign nephrosclerosis, you see the only granular surface is there. Here it is called as flea-bitten kidney. In the microscopy, you're finding fibrinoid necrosis, which is the eosinophilic granular change in the blood vessel. See, fibrinoid necrosis wherein you see that the cell details are lost and the resultant is eosinophilic smudgy material that is seen in the blood vessel. Okay, onion skinning, there is intimal thickening, hyperplastic arteriolitis because of increase the layers. Intimal thickening will be there. Then fine concentrating layering of collagen, accumulation of pale staining material, that is because of the proteoglycans and the plasma proteins which are stated. Okay, then it correlates well with renal failure in the malignant hypertension. So here you are seeing the glomerulus. It is having a narrowing of the lumen. Here you are seeing the onion skinning, which is very characteristic of the malignant nephrosclerosis. So the clinical features: hypertensive crisis, I told you, is loss of consciousness, convulsions, headache, nausea, vomiting, microscopic proteinuria, and associated renal failure that can occur as a result of increased pressure and malignant hypertension. So now coming to other vascular lesions which can be seen in the kidney. Until now, we have talked about the cystic diseases, the congenital, acquired, neoplastic, non-neoplastic, adult polycystic, infantile polycystic kidney disease, simple, acquired, and neoplastic, right? And after that, we've dealt about the vascular lesions, benign nephrosclerosis, and the malignant nephrosclerosis. Now I'm going to talk about vasculitis as a part of the vessel disorders which are seen in the kidney. Okay, what is vasculitis? Inflammation of the blood vessels, mostly seen in autoimmune diseases with circulating antibodies. So the renal vascular disorders associated with vasculitis are small vessel, medium vessel, large vessel. Large vessel, you know, the giant cell and Takayasu. Medium-sized pan, Kawasaki. Small vessel, HSP, good pasture, Wegener, microscopic polyangiitis. HSP, while talking about the IgA nephropathy, I also spoke about that. Good pastures, when I spoke about RPGN, anti-GBM antibody disease, we spoke about good pastures wherein the lung is involved. Wegener's granulomatosis and microscopic polyangiitis also examples of quasi-immune type of RPGN. Okay. So what we see in PAN? Affects arcuate and intralobular arteries with necrosis. Killing is with aneurysm and microinfarcts. So P ANCA is positive here. The glomerular ischemia and focal segmental sclerosis fibrosis is seen, and tubular ischemia and dropout is seen. So PAN is usually affecting arcuate and intralobular arteries associated with necrosis. So whenever there is some injury, you're trying to cover it up. So the healing is occurring with microinfarcts and aneurysm. This is about the vessels. Coming to the renal parenchyma in glomerulus, because of vasculitis, there is ischemia, focal segmented sclerosis and fibrosis in the glomerulus, tubular ischemia and drop. Priyanka positive. Wegener's, it's a form of systemic vasculitis. Priyanka is positive, that is cytoplasmic pattern. Giant cells around the renal artery, granulomatosis, giant cells, remember that, granulomas. Obviously, in the granulomas, you find histiocytic infiltrate. So there is destruction of Bowman's capsule. So here, this is the examples of the microscopic pictures wherein you see the vasculitis changes. You can see numerous leukocytes affecting the vessel wall. Okay. Now coming to the thrombotic disease that affect the kidney. That is DIC, TTP and HUS. HUS is two types, type 1 and type 2, wherein the diarrhea is associated or non-diarrhea associated, and TTP and DIC. Okay. So now, how do the presentation be for a thrombotic disease patient? It will be thrombocytopenia or anemia, decrease in platelets, neurological symptoms associated with stroke. Obviously, whenever there is the vessel, blood flow should be maintained properly. If there is a thrombus in the vessel, what happens? There will be occlusion, and because of that, there will be ischemia that can lead to a stroke. HUS and E. coli poisoning, metastatic breast cancer, drugs associated with OCP, and usually the treatment is by plasmapheresis. Okay, what is a pathology? There will be arteriolar and capillary microthrombi, endothelial cell injury, ischemia and collapse of the glomeruli, and secondary tubular changes. It's all about, if you just think with common sense, thrombi is something which is trying to occlude. So what can happen at the organ level? Okay, think like that and you'll get all your answers. Okay. These are the pictures which depict a lot of hemorrhage here, okay, in the necrosis. Now coming to renal infarcts. We finished about the thrombotic disorders, vasculitis. Vasculitis, I told you, autoimmune type of rapid glomerular nephritis. We spoke about other things, and after that we spoke about thrombotic disorders. In thrombotic disorders, you should know about HUS, hemolytic uremic syndrome, that can be associated with diarrhea, not associated with diarrhea, and also DIC and TTP. Okay, TTP is usually associated, seen in patients wherein the disease is usually progressed as a result of the thrombotic factors. It's like the same presentation as the other thrombotic diseases, wherein there can be some genetic mutation related to some the von Willebrand factor. So this you also should look into the blood vessel chapter, and then you have to look into the kidney chapter so that you can just know, combine both together and then read for a thorough understanding. Now coming to the other one, that is renal infarcts, that is emboli from mural thrombi of the left heart, vegetative endocarditis or aortic aneurysms. They can be clinically silent and can be discovered during a surgery or autopsy. So how they look like? The renal artery stenosis is because of these renal infarcts, usually wedge-shaped or multiple bilateral. Recent infarcts are yellow-white ringed by hyperemia. Old infarcts are fibrous scars, loss of cortical architecture. Okay, these are the anemic infarcts you're seeing here. So what happens is the emboli from the mural thrombi of the left heart can travel. Okay, even the vegetative endocarditis which is there, that is affecting the heart, the inflammation that can actually lodge get lodged from that and cause a renal infarct. The same with the aortic aneurysm. Okay. And then you can see that these are wedge-shaped infarcts. Okay. And they are having yellow, white, and ringed by hyperemia. The old infarcts are fibrous scars with loss of cortical architecture. This is about the renal infarcts. Okay, so this is the picture which is showing the hemisection wherein the renal infarcts can occur. And then here is the gross appearance of the renal tissue wherein the renal infarct, usually the pale white infarct, which is just cut here, can be seen. Okay. So this is about today's class. We finished glomerular diseases, tubular diseases, cystic diseases, and vascular diseases. In the tomorrow's class, I'll be talking about the nephrolithiasis. I'll be talking about the renal neoplasms in detail. And then by tomorrow, we'll be finishing the kidney chapter, right? Thank you very much for your patient listening.